So it's all of our pleasure to be here. Thank you to Jensen for supporting this. And thank you to Lung Cancer Initiative. That grant that was mentioned actually was successful in reaching people. The first patient is due to get his first CAR infusion next week. So first query question for you is, what proportion of non-squamous patients do you think are tested for all of EGFR, ALK, ROS1, BRAF, and PD-L1? So, this isn't even a comprehensive list, right? The reason I chose these was that there's actual literature on it to share with you on what people are doing. But I would say that if you're only testing in practice for those markers, it's something between suboptimal and malpractice, depending on what kind of mood you're in. So here's why it matters. For some reason, there's an obligation in thoracic oncology to present biomarker data as a pie chart. Right? Since the early days, I've never seen it presented graphically any other way, but I think there are a few important themes here, which is that for the targets that we already have drugs against, and have had for a long time, like EGFR, the drugs keep on getting better, right? When Tom Lynch presented on gefitinib, we had a PFS of 10 months, response rate of about 60%, and toxicity better than chemo. I remember that grand rounds. I was just a resident and thought I was going to do melanoma at the time, until I met a lung cancer patient. And that was actually one of the things that started getting me thinking about lung cancer, that lecture. The other theme is that the unknown and unactionable keep shrinking in that pie, right? We have new drugs that keep improving our standard of care. From an advocacy perspective, this is data you absolutely have to know. This is why it matters, which is that data that it improves survival. By common sense, these drugs are so good, you knew that it improves survival, but it's nice to have data to cite for an advocacy community. I'm happy to share slides with anyone who would find this helpful. But something interesting going on at the curves at the bottom from the Johnson study, which is that if you look at patients who have an actionable genomic alteration and get the right drug, of course, that's the survival curve on the top. But look at those two curves at the bottom that are near identical. One of those are people who have an actionable genomic, have no actionable genomic alteration. The other is people who have an actionable genomic alteration and never get drug, right? So there's no biologic advantage to having one of these unless you get the right drug, right? It's like your front door key is useless except in your front door, where it opens the door. I think all of us here, most of us, would argue that survival is probably the second most important reason that lung cancer is treated. I think most of us would argue that quality of life is the most important one. Quality of life is extraordinarily complex and multifaceted. Some is none of the oncologists or the advocates' business, but in terms of physical quality of life, there are two dominant drivers for the cancer patient. One are the side effects of drugs like the ones Dr. Garst is giving, because mine, of course, at UNC, they're toxicity free. You showed up, I gotta do it. Even wearing beautiful dark blue there. So one is the side effects of the drugs that we all give, but the other thing that's really important is the suffering that the cancer causes. And if we want to maximize quality of life, we can really never argue any of these, but better drugs that knock the cancer down more and knock the patient down less, that's like great taste and less filling, right? Those are drugs that are going to really improve quality of life. And of course, targeted therapy, which has these properties relative to our other classes, does this nicely, as common sense would suggest, and data actually supports. But we're actually not doing that well. So if you look at non-squamous patients, the ones where I would say biomarker testing is absolutely mandatory. Oh, shoot. Anyone happen to have a power cable? Gosh, I'm sucking multiply here. All right. Well, we'll hope this. I'm going to turn down the brightness on this screen, so hopefully it gives us a little more time. But you can see that it's like 49% or so getting all 5 of those biomarkers. And if you look at the Flatiron data, it's really no better. If you look at NextGen, it's even worse, dropping down to 44%. And again, as common sense unfortunately suggests, we know about the dramatic racial disparities in the US, and this rate is worse for Black patients compared to white patients. Looking at the bottom right, you see there is some improvement over time, but really inadequate and plateauing off. So what is the optimal standard of care? It's actually rather simple. There are easy buttons out there. I have no conflict of interest with any lab company whatsoever, but there are at least 3 that offer an easy button, where for one bill, you get liquid testing, meaning on blood, and tissue testing on tissue, and you get a good DNA and RNA next-gen panel, the good stuff, if you will, that is very broad and sensitive, that covers essentially, that you just get it right? You don't have to memorize all the new biomarkers, and they even come with suggestions on what to do. So moving on to topics on so we're talking now about the problem. We have a big problem with not getting testing at all, or not getting the good stuff, the maximally sensitive and maximally broad testing. My next question to you is, what proportion of patients potentially eligible for targeted therapy are ending up getting it? Is it 10, 29, 64, or 80? Yeah, so there's data on this. Here's what it looks like, right? So you basically have this Swiss cheese model of where things can go wrong, where all these different steps that have to happen to get it right? You have to actually be eligible, right? Mostly non-squamous. You have to collect the specimen appropriately, which is less of a problem in academia. In academic places, you have like 3 different proceduralists fighting over who gets to do the procedure. But the smartest oncologist I know, no offense to either of us in present company, is not in the room, is not even in academia, is in private practice in the middle of nowhere, New Jersey. And so someone I regard as smarter than myself in a very different environment can't practice as well. And he has trouble convincing people to go after tissue in lung cancer patients, and assures me that that's not unique to his geography. So you have to actually get the tissue, you have to evaluate it. Your test has to be the good testing that's actually going to find the result. You have to look at the report, you have to do it, and where are you? You have 29% of patients lost by the time you get through all of that. It's a large rate that are lost along the way, who have these actionable genomic alterations that are not actioned. And I'll tell you by anecdotal experience, I probably personally see at least a half a dozen a year. When Pembro was having its phase 1, there were more, but that are come for another reason, and on the report there's something sitting there that's actionable that was never actioned. So much as I love getting people on trial, if they have one of these, obviously it's the right thing to do. This is an example of the promise to weave in the newest data, but of one of the new targets coming down the pike. There are 2 newest targets in lung cancer. Red is a few percent of adenocarcinoma, like ALK. It's a gene fusion that's more common in folks who've never smoked. And I think drugs like selpercatinib and pralsetinib, the new RET drugs, sit on a pedestal together with osimertinib for EGFR and alectinib for ALK, that have reached not that first tier that Dr. Lynch set, gosh, what is this, 15 plus years ago? Wow, it's longer than that, isn't it? It's 18 years ago. We're all getting older. 18-ish years ago, but actually on a second pedestal, where our frontline response rates have crept up to the mid 80% range. The drugs are even less toxic. They have beautiful brain penetration. And so sort of raising the bar even further for what an optimal targeted therapy would be. And in terms of the pie of unactionables shrinking, KRAS is the most common mutation driving adenocarcinoma of the lung. Actually, it's the most common mutation driving human cancer, present in pretty much, at some rate in pretty much every human cancer, and particularly in GI malignancies. This one has different isoforms, different subtypes, but the one that's most common, representing about half of KRAS in lung cancer, is KRAS G12C. That's a typo that should have said adagrasib as example. But we now have 2 FDA-approved drugs, adagrasib and sotorasib, against this historically undruggable target, and others moving along rapidly. I think you guys funded Chad on some of the KRAS work, right? So also LCI grants approaching clinic for KRAS as well. Optimal supportive care. As a field, and I mean this broadly, academia, practice, industry, nurses, nurse practitioners, no one would ever hire a PA, right? NPs are better. But jokes aside, that one flopped really badly. But as a total field, all of us, how are we doing in symptom management? if you look at the literature on stigma, on shame, on all that sort of stuff, it's very common that patients will report their oncologist is doing very well, but then say the world at large is doing badly, which makes a lot of sense, right? Hopefully we're making bonds with our patients, even those that are not doing optimal. And so the fact that in this room not only gets 5%, I think speaks very loudly. So, I wanted to speak not so much about this drug as the culture around this drug that has been instructive to me and how we think about palliative care. So some of you may know, some of you may not know that there's a new supportive care drug, FDA approved for all but one of our small cell regimens. The name of the drug is trilaciclib, and it's given with small cell chemo to protect the bone marrow progenitors that make blood cells. And what's been proven is that in addition to protecting those cells, it does just what you would hope it does. It improves patient-reported quality of life, particularly around fatigue. But I didn't really want to so much talk about the drug as it's instructive to me, because it's the newest supportive care drug, frankly, the first new supportive care drug in lung cancer in well over a decade. And the reception that I think it's gotten from most of the thoracic community and certainly the community at large is it's a drug that improves fatigue, protects counts, better quality of life, but does not budge survival in one direction or the other. And it speaks to my mind, to a lack of enthusiasm about supportive care, that this is not something sort of embraced quickly. The company doesn't like that I say this. I prescribe it with a yawn, right? And yeah, okay, it doesn't improve survival. It's not high science. It's a little boring. But I prescribe it with a yawn for every single patient because it reduces fatigue. And nobody is excited about this, and nobody's excited about developing similar and other supportive care drugs. It's really, if you look at drug development, very, very, very little is going into supportive care. That's just the quality of life data to back up what I was saying on the last slide. So, patients come to our clinic specifically, usually looking for a specific clinical trial or with the question, is there a clinical trial? And I mentioned that in the case of the molecular testing, often the answer is, well, what about the RET on your molecular report? Or what about the KRAS G12C on your molecular report? This is also a lot of what we and anyone else in a tertiary quaternary clinics do all day long, which is, okay, maybe we have a trial for you, maybe we don't, but this is what we end up spending half that consult doing, is getting a new perspective on unaddressed symptoms. I strongly suspect, and this is confession, not endorsement, that if someone were seeing one of my patients, they'd be doing the same thing that I'm doing when I see other people's. That fresh perspective and that ability to spend time and sort of reset is extraordinarily, I'll give you looks of death. I care about supportive care. But this to me, the lesson from that, other than I'm not perfect, is that the value of that palliative care consult. Because now you have someone who walks into the room who has half an hour to spend that doesn't have to talk about prognosis, drugs, future options, trials, insurance, all these millions of things that I don't know how we're supposed to do in the half hour that we have. They have time set aside purely and only for that, and they have a laser focus on that. And no matter how good you are or your oncologist is, I think that's a value. So how are we doing, and I mean this very globally, at offering every patient a clinical trial of promise? Does every patient get offered this and have that opportunity if it's consistent with their values? No. I haven't heard a single yes in the room. And I'm seeing a lot of people subtly doing that. So, I've sucked in the, messed up on the care everywhere, but by a show of hands, what do you think the rate of accrual to lung cancer trials in the US is? Do you think we're talking like 2 to 8% of patients, 15 to 21, about a third, or about half?
So 2 to 8%, raise your hands.
15 to 21? About a third? About half. So I think this room already understands the problem very well. So this is one data set looking at that. It's actually the most optimistic I could find in the entirety of the literature, hit at 8%. And there are other estimates as low as 2%. So it's very, 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 very low.
Conclude that they're going to have the same outcomes and they won't try, and it becomes difficult. But if I get a no today, I'm gonna be right back this afternoon. I mean, it's how we change, that's how we invoke change. It's slow, it's kind of painful, but it's worth it. And we have to really dig deeper to get that level of enrollment.
Yeah, and I think, again, the burden falls on the provider, not on the patient, right? To explain in plain English how trials are vetted, and then to look people in the eye, and assuming you believe it, because, you know, third grade ethics, to say, this is what I would do for myself or a loved one, to be comfortable to take that step. Yes, you also talk about alternatives, but when you believe to that extent, I think there is an imperative to say it.
So one of the themes of drug development are new modified antibodies, and they fit a bunch of themes. The one that will come to a clinic near you first are antibody drug conjugates. So if an antibody is a Y, what you're doing is on the, you have a target that you know, like HER2 is this a case example. It's a mutation present in about 2% of adenocarcinoma, and then on the common region you have a toxin. So you're using the antibody as a smart bomb, so to speak, to get the toxin into the cancer. To editorialize this a little bit, this is chemo 2.0 at best. That might even be optimistic. This is chemo 1.5. That said, chemo 1.5 is better than chemo 1.0. And what I mean by this is that if you look at the toxicity tables of these drugs, they're chemo-like but a hair better. If you look at the shapes of the PFS curves, they look exactly like chemo. Look at the OS curves, they look exactly like chemo, but in both cases shifted up a little bit better. And so I think you're gonna see these, there are already approvals in oncology, and you're gonna see a lot more in future years. The HER2s are coming along, the HER2 is used, right? Our Beck's drug against HER2 mutation is TDXD, an antibody drug conjugate. The TROP2s, which is what I'm showing you here, are coming down the pike probably in the next year or two. They will make a difference for patients. You're gonna see them everywhere, but probably not massive gains if we're gonna be honest about it among our friends.
Are those drugs for people with PD-L1 positive?
These are pretty irrespective of PD-L1. They're agnostic to that biomarker, these antibody drug conjugates. What's really interesting to me though, is, you know, in the conversation about are these targeted therapy or are these chemo, presence of target isn't much a predictor of whether these drugs work. That's not targeted therapy. It's not having those properties that Tom Lynch established so many years ago. They're not that much less toxic than chemo. They don't work that much better. They're not oral. They're not brain penetrating. They're a little better. They're an advance. But what the driver behind this is probably, and no pun intended there, is that the solubility of the toxin. So once the toxin is cleaved from the antibody, they have diffusion properties. They can kill that cell, then they can kill the neighboring cell. And the reason it was designed that way is that even if you have a target present like TROP2 or HER2, not every cell is going to have it. So they were designed to have these diffusion properties to have a bystander effect against the antigen negative cells. The problem is that also allows them to diffuse in a chemo-like way. The linker further between the toxin and the antibody is very weak. So it's not only cleavable in the presence of target as a true targeted therapy would be, but in an acidic tumor environment, it'll cleave. So this is all for better and for worse. Broad activity like chemo has, but also broad toxicity like chemo has. And we just got a press release, July 3rd, what are we on the 21st? So it's days after I made the slides, but 2 weeks, a little more than 2 weeks ago, that this particular agent, which is a TROP2 agent, was studied randomized against docetaxel, met the primary progression-free survival endpoint, and there's still ongoing monitoring for survival. So that's part of why I say this will probably be approved in the next year or two. That's not a positive trial yet, by the way. It was a dual primary endpoint. So to call it positive, the company, I think it's AZ, will have to wait until they also hit on survival, which with chemo always hits later than progression-free survival. Here's a class, though, that I'm personally way more excited about. BiTEs, or bispecific T-cell engagers. This is a kind of bispecific antibody. So bispecifics are where instead of having both arms of that antibody targeting the same thing, each side targets something different. But in this case, what you do is you take a target of interest, in this case DLL3, which is present on most small cell lung cancer cells, and the other side is CD3, which binds T cells. What's really cool is by so doing, you bring them into physical proximity. The T cell makes a synapse with the tumor cell and kills it in a lot the way that T cells kill tumor cells that normally bear their antigen. This is probably what's going to be, this is true targeted immunotherapy, right? You're taking something uniquely present on the tumor cells and actioning it. And I use it as an example of a broad class targeted immunotherapy that includes CARs, TCRs, trucks, neoantigen vaccines that are what I personally am sort of investing my life in believing are where we're really going to make a next massive advance for patients. This drug right now is being evaluated in small cell, and it's not so much the response rate that has me excited. It's less than a third of patients, even if you look at the highest doses. It's that in the early goings, there seems to be some durable responses here. What is durable? I don't know, because the longest are and counting. It's early follow-up. But to me, this is sort of a evidence of principle that targeted immunotherapy as a whole might really help people. BiTEs are really exciting because they're off the shelf, right? You don't need a big rigmarole to make them. On the other hand, the other antibody-derived therapy that I spend a little more time with, CAR T, is a living product. Once it's in the person, they have it for life. You only need to get it once. And so we'll see how that plays out in the clinic, but I think they're, for now, examples of what's exciting, and I'm really hopeful that tarlatamab gets approval in the next year or two. We have it on trial at UNC for small cell for maintenance after frontline carbo-topo and a PD-L1 inhibitor. We have a patient on compassionate use for it who's doing amazing, thank God. And we have a bispecific of DLL3 and CD47 coming down the pipe that I'm really excited about it. Our other related product, just to mention, that fits this theme is the one that that LCI funded. The GD2 CAR is a very similar idea of antibody-directed cellular therapy. And that's actually a pan-lung cancer drug. It's like back to 1970s trial design, which is it's any lung cancer because that's where the target's present. So another thing that I'm hopeful will come to approval relatively soon are TILs. So TILs are where you surgically resect a piece of tumor and you remove the lymphocytes, the immune cells that are there, with the idea that if they're there, they're probably attacking tumor. You expand them in the lab and you give it back as a drug product. And the company that's in the lead for this is called Iovance. I have absolutely no relationship of any kind whatsoever with Iovance, by the way, but I think they're going to be the first to clinic. They have some FDA hurdles to overcome, which I can relate to. But they have some press releases, which is why I have no pretty pictures for you, that I find really interesting. The most recent one was on their heavily pretreated patients. That's what a lot of the thoracic community is talking about in that second bullet. But if you go back to their last investor call in January, their frontline patients, granted with the very small numbers, did really, really well. And I don't know if it's true, right? It's the law of small numbers. We'll see what happens when they treat more people. But of their 5 truly treatment-naive patients who had never gotten anti-neoplastic therapy, 4 out of 5 had a response. It's 5 patients. Let's not make too much of it. But it's interesting, right? It's provocative. And certainly for pretreated patients, if they can overcome their last FDA hurdles, hopefully they'll be approved in the next year or two. And there are other companies, like for example, Lyell, that are using informatics to better select the product. And I think with better product selection of TILs, I think this is really first generation, which actually makes me more excited, right? Because if this is only first generation, what can second, third, fourth generation offer us? And I was going to do a survey. We can do a show of hands, I guess, instead. Which treatment class do you think will make the most difference for patients? Show of hands if you think it's antibody-drug conjugates. All right, I poisoned the well on that one. What about bispecific T-cell engagers, BiTEs? CAR T? See some show of hands. Personalized cancer vaccines. All right, those are the people I've bribed. And new targeted therapies. I spend a lot of time on vaccines. So I think there's a lot that's exciting. I like to end my LCI talks with cute kids pictures. You have my 3 daughters and my wife at left. You have Shaylee's munchkins at the middle and Tammy's fur kids on the right. And being a snarky oncologist who likes to try to make jokes, I was going to ask this, and I thank you for the kind.